in terms of experience with communities, with advocacy, with policy, and particularly with regard to health. And so to my right, Jamal Miller is the Director of the Office of Health Equity for the state of California. Dr. Kevin Sharon is Director of Chronic Disease Prevention at the California Department of Public Health. Caitlin Worley is a Program Director at Toyota Health Services. She's been surprised for having the most arduous travel to get here. Thank you very much, Caitlin, for coming. Dr. Tomas Aragon is Public Health Officer for the County and City of San Francisco. And Sarah DeGia is Director of California Health Network. All of them have given time and expertise to be with you here today and probably delivering an important message. So to start with, I'm going to give you the punchline. More hospitalizations, greater costs, and more death than any other condition. In other words, it's darn important. Number two, inequities determine occurrence, cost, and death from chronic disease. They go hand in glove. And where you see high chronic diseases, you're going to see high rates of inequities and vice versa. Because of what happens when people come down, especially with multiple chronic diseases. Chronic disease and inequity are preventable. And I want to underline preventable. That means they do not necessarily have to occur. And it's chiefly through policy change that we can prevent them from happening in the first place. And number four, some places in California are doing stellar work to prevent chronic disease and to change inequities. And much more needs to be done. And that's where you guys come in, because we need folks to be true prophets out there in the community and policy work to let others know that this work not only has great examples and pioneering efforts in California, but there's more that needs to be done, and we need to find ways to make sure that gets done, or we're selling the population short. I'd like to talk about the context for today's discussion. It's really important. 5 trends are igniting efforts for prevention and equity, and you're going to hear about all 5 of them today, I believe. Number 1, the state's economy has improved, but not all Californians are sharing in the benefits. Economic drivers like development, transportation, education, and jobs are increasingly recognized as policy needs to improve health and equity. California has embraced the Affordable Care Act to the benefit of 4 million previously uninsured citizens. Less recognized, but potentially more important to improving health and reducing costs, are the incentives provided by the Affordable Care Act for community-linked care and preventing illness in the first place. Dozens of chronically under-resourced public health departments and community organizations are receiving Affordable Care Act funds now to prevent chronic disease and improve equity. And you're going to hear about some examples today. They're turning out amazingly creative and effective models that we need to be proud of and promote and let our decision makers know about. While the state government's investment in prevention is going backwards, witness the auditor's recent report on diabetes prevention spending, which here in California is 0. State agencies are increasing collaboration with stakeholders to advance prevention and equity through efforts such as the Health and All Policies Task Force, the California Wellness Plan, the Let's Get Healthy California Initiative, and the CalSim planning process. In other words, California is being extraordinarily resourceful, even without funding. Even in the absence of new state funds, we've managed to do a lot. And it's reaching across the aisle with the private sector, with smart spending in government, with the limited resources that are available. It's getting the job done. California's business community is a fertile and increasingly involved group for promoting prevention and wellness. CalPERS, Pacific Business Group on Health, Silicon Valley Leadership Group, The Health Technology Forum, the Federal Reserve Bank, and many others are extending incentives for wellness beyond their walls, beyond the realm of what we usually consider business and business interests. They're developing new tools to make healthy choices easier and marshaling investments for social impact based on interventions that prevent chronic diseases such as asthma and diabetes. And number 5, residents in 14 of California's most disadvantaged communities involved in the California Endowment's Building Healthy Community Initiative aim to change the very policies and barriers that underpin social inequities and their consequent risks for chronic disease. They're doing this by building resident power, developing youth leadership, collaborating, partnering, and convincing others that health can happen in their communities, and indeed it does. So I want now to turn this over to our panel of experts to tell you in their words, in their pictures, how this great job preventing chronic diseases through a social equity lens is getting done here in California. First we have Jamal.
Thank you, Dr. Flores, for the introduction and setting the stage for today's presentation. I'd also like to thank the California Endowment, California Health Policy Forum, and the Foundation, California Healthcare Foundation, for pulling together such an important discussion that will require all of us to some extent to take action. As much of what we'll talk about today, especially with a lot of familiar faces and familiar panelists, we talk about it a lot. But we also are equally as committed to taking action, to go upstream and address the root causes. And I really appreciate the framing today around the social equity lens. And why I really appreciate that is that we know when we go upstream to get at root cause challenges that contribute to persistent health and mental health disparities and inequities, we have to take into consideration the social determinants of health and those facets that often go unrecognized from a strategic standpoint as to how we get at the social determinants of health or even the determinants of equity to address the root cause issues and in a sustainable and meaningful way affect change that will likely exceed the tenure of all of our respective positions. So I'm honored to be able to talk about the social equity lens today from the perspective of the Office of Health Equity, given our role to catalyze and to convene on behalf of the state of California this journey on achieving health equity. Dr. Flores commented on the expansion of care and coverage with respect to the Affordable Care Act, cover California, particularly California, and Medi-Cal expansion. And one of the questions that I often, consider rhetorically, but it is a very real question that we have to explore is, as people get access to care and coverage, from a social, environmental, physical perspective, where are we sending them back to? Once they go see that new doctor, or once they get discharged from that hospital after having a medical procedure, from a social perspective, what type of community are we sending them back to? Because if it's not healthy from a health and mental health perspective, then that persistent cycle will continue down that path of a costly, broken healthcare system. So I applaud today's focus on the social equity lens. I'm proud to lead the discussion today and tee it up for my colleagues. Some of you, most of you, I'm sure, are familiar with what our charge is at the Office of Health Equity, but I never like to take it for granted. Our charge is really to provide a key leadership role, as I stated before, to reduce health and mental health disparities in vulnerable communities. Health equity, a fairly new term for some at the federal and state level. An office like ours is typically called the Office of Minority Health, which to some extent is accurate, but health equity, in my opinion, is far more expansive and inclusive, in that it really gets at the broader vulnerable communities that leaves none of us untouched. And health equity is simply efforts to ensure that all people have full and equal access to opportunities that enable them to lead healthy lives. And in order for us to do that, to achieve health equity, we've got to take into consideration how each of these social determinants of health that you see listed here how do they uniquely intersect at each level to give us a real chance in California to transform the conditions in which people are born, grow, live, work, and age for optimal health, mental health, and well-being. If you look at each social determinant of health, whether it's income security, housing, food security, discrimination, and other pressures, there's a unique interaction, interface at each level here. If you think about people, communities, environments, and healthy societies. And this is where we need to go with respect to going upstream. To highlight and kind of set the tone to identify those a key social determinant of health that is far more influential than who your doctor and who your hospital, where you happen to go to get your hospital services. To highlight income security, there's an uneven distribution of household wealth across racial, ethnic groups in California. On the left side, the pie chart, which is kind of small, you might need to put on 3 pairs of glasses to see this. But you'll see on the left side the households in California broken out by race and ethnicity. On the right side, you'll see household wealth in California by race and ethnicity, just to highlight how uneven income is distributed across the state. You'll see African American households represent 6% of California households, but hold about 2% of household wealth. So when you think about social determinants of health, and particularly in our culture in America and California, having the means and the resources with respect to income is a key indicator as to your ability to have access to the amenities and the resources that are associated with optimal social determinants of health and outcome. And to look at how this plays out from a mental and physical health perspective, and to look at this epigenetic dynamic, economic disparities impact infant health even before the baby is born. So if the baby, we're looking at a situation that's highlighted here in the study that was produced by a first year research at the University of Colorado. It studied poor expecting mothers, and elevated toxic stress levels or cortisol levels associated with the conditions of poverty. And not only did they identify that the expecting mother's cortisol levels were elevated during pregnancy, but if you jump to that third bullet, this is the first research that measures cortisol in infants and relates it directly to the socioeconomic status of the mothers, the status of the mothers during pregnancy. So even before the baby is born, the baby is predisposed to early morbidity, developing serious disease earlier in life. And this is a key social determinant of health when we think about income security. And how does that play out as the life course progresses? We look at a situation such as asthma. If you're a baby that comes from a poor environment, or your income insecure, your family is income insecure, when you think about decisions associated with where I want to live or own a home, and you happen to live in a community that's far more vulnerable when we think about the air pollution burden, and then we look at from a downstream perspective, pediatric asthma disparities in California, it kind of makes sense with making the connections of our health and our life expectancy and connecting that back to the broader social determinants of health around environmental health, place-based comparisons and such. We see asthma prevalence, and my colleague, Dr. Sherman, is going to speak about this later, but asthma prevalence is highest in black children, 50% higher than that of white children. Asian children also have disproportionately high asthma prevalence, and when you break it out, for example, Filipino children have an estimated baseline asthma prevalence of 31.5%, which is higher than any other group, and more than 2 times higher than that of white children. Black children have much higher asthma hospitalization and ED visit rates. When we look downstream, once again, at morbidity, preventable emergency room visits, so 4 times higher than among white children. So you may ask, okay, we see these downstream disparities. How is this connected to income security and these other social determinants of health? I'm glad you asked. Climate change affects all of this. When we think about the social, environmental, physical dynamics beyond the doctor, beyond the hospital. So on the left side, to just do a demographic comparison, the darkest spots or darkest regions that you'll see centrally located from a vertical perspective on the left side is where most communities of color, which shows you where most communities of color are concentrated. On the right side, you see the pollution burden in California. So the darkest or the hot spots, that's not good. So it just so happens that where many people of color live, on the left side, the pollution burden is strongly correlated with where they reside. And the option to maybe relocate or move to an area that's less affected by adverse environmental health conditions, it can be challenging, going back to that income security illustration that I showed earlier. So I just wanted to use those as an example to frame and tee it up for my colleague, Dr. Sharon, from our Center for Chronic Disease and Injury Prevention, to just focus on how does the Office of Health Equity and the California Department of Public Health, we know that as a collective, and especially with community-based organizations and many of our stakeholders, we spent a lot of time on the right side of this public health framework. But we made an intentional strategic commitment that we can only achieve through collaboration and partnership to go upstream in how we address the social determinants of health associated with living conditions, institutional inequities, and social inequities. And the challenge is, and when I sat in a room similar to this for my Senate Rules Committee, is we often get this question: how are you going to measure the outcomes? How do you know when you succeeded? And, we have some indicators, we have resources we can pull together to measure our success. But the challenge when we go upstream is that there are a lot of variables associated with that. And there are a lot of dependencies, interdependencies between the public sector, private sector. But that does not absolve us from the responsibility that we have to bring communities like this together, to share information, to share best practices, and to have a scaled, strategic, collective impact approach to going upstream and achieving health equity at each level. One of our mandated requirements is to create a statewide health equity plan that many of you in the room are to some extent familiar with because you helped us create this plan. The vision of this plan that we're being a catalyst for in implementation is that everyone in California has equal opportunities for optimal health, mental health, and well-being. Our mission is to promote equitable social, economic, and environmental conditions to achieve optimal health, mental health, and well-being for all. And then the central challenge for the statewide plan is to mobilize understanding and sustain commitment to eliminate health inequity and improve the health, mental health, and well-being of all. And in order for us to do that, it's going to require everyone's collective impact and influence in our ability to do that. And I'm honored within the California Department of Public Health that once that plan is approved, it's still under review, we're hopefully looking to have it approved and disseminated here in the coming weeks or months. I have a colleague in Dr. Kevin Sharon that we can work collaboratively to operationalize health equity within CDPH, exercise our interagency agreement with the Department of Healthcare Services, but strategically align with existing partners such as CPAN, such as the California Endowment, and others that we're already doing some work with to achieve health equity. We can't do it alone, but we take a great deal of pride in being a catalyst on behalf of the state of California. And with that said, I'd like to hand the mic over to my colleague and partner, Dr. Kevin Sharon.
And I'm going to grab the clicker here and try and continue the conversation about the health equity lens as it applies to our Center for Chronic Disease Prevention and how we operationalize that at the state level and how we go to those set of slides. So I'm going to give you an overview of the prevention angle. I'm going to talk a little bit about health and all policies. I'm going to talk about trends in chronic diseases and prevention. And then I'm going to close it out with some local examples of where local projects, policies, best practices can inform state policies. And these are just to tease our imagination of what we can all do together. And actually, one of the examples, we'll go to one of those areas on the asthma slide, which I'll show where there's a concentration of people of color. So we have the spectrum of prevention, and at the top, you'll see health and all policies. So health and all policies really cuts across everything we do in California. In California, I think leads in the nation bringing this concept, which, as I understand it, had some origins in Australia. And the whole notion of health equity had some origins in the UK. So, we take from our sisters and brothers around the world as to how to deal with these issues. Health equity lens in the European Union, they have health coverage for all of their citizens. That's not an issue in all the Western countries in the European Union. But what they found was there were tremendous disparities despite everything else that they were doing. And so it comes down to these social determinants of health once again that were so well articulated by Sir Michael Marmot. Now, changing organizational practices, fostering coalitions and networks down to the local levels. We do that at the state level as well, working with provider organizations, and finally down to the individual level, empowering individuals, but ultimately we're empowering communities. Health equity lens tells us that we have disenfranchised communities where even if you provide health access, you're not solving the problem. There's still fundamental root causes which are not being addressed. But when the community becomes more empowered, when it becomes socially enfranchised, when it becomes less economically disadvantaged, that's where it begins to make all the difference in the world. So here are some examples at the state level where we have health in all policies that's already going on. And I think we're going to notice an example in my colleague's slides from San Francisco of where Caltrans comes in. The Air Resources Board, we're going to see connections with respect to asthma. CAHPF, Jamal and I work together with them on health and all policies, climate change and health, and we're trying to tie these pieces together. So there's a conversation within CAHPF for health equity, and they're looking at communities that are disadvantaged from an environmental justice standpoint. Department of Food and Ag, so many communities in California where our citizens are dependent on locally grown fresh fruits and vegetables. That's a good thing from a health standpoint. That's going to help drive down our diabetes rates. That's going to make a difference. So here's a partnering agency that we can work with. U.S. Department of Agriculture, of course, being another. Department of Managed Health Care, well, that's a traditional health agency. So you see how these connections work. So what are some of the trends for chronic disease in California that we have to concern ourselves with? Certainly we have to be concerned about childhood obesity. We know that 1 in every 9 California children is already obese. We know there are disparities for children of color. We know that 1 out of 3 adolescents are obese. And we know that 1 out of 2 adults in California are obese. Obesity by itself is one of the key drivers of type 2 diabetes. So when you hear about the diabetes prevention programs in the Toyabe tribes, health services in that community, in that tribal nation, these are the sorts of things that have to come together and work together from a policy standpoint. But we have so many other disparities going on too. We have a great increase in the number of people with diabetes in California. That's a national trend. Some states as much as a 100% increase. But even in the West, more than a 50% increase. Second only to the southern part of the United States. Cardiovascular disparities, whether it's African Americans, Latinos, cancer, also disparities, particularly in African Americans. Renal disease, you have disparities coming in with Latinos and African Americans as well. Diabetes even involving the Asian population disparities. Late diagnosis of certain cancers. African American women being diagnosed late with breast cancer. Why is that? What can we do about it? And the asthma disparities that Jamal has already pointed out. Why is it that black children are coming into the emergency department at a rate 4 times that of white children throughout California? Well, I would suggest that one of the factors we need to include is that environmental justice lens. The health equity lens applies to the environment where there are those particulates in the environment, whether it's along the Interstate 5 corridor in the Central Valley, or it's inner-city Los Angeles, or it's Richmond, or any of these communities where we're seeing these patterns. But we also see it in the Central Valley, and I'm going to have one example at the end. What is happening with deaths in California with respect to chronic diseases and injuries? They account for 75% of all the deaths in our state. So, the large ticket item for health care costs, $27 billion in 2003, and and only going up. The bill just keeps going up, and as we add more folks to cover California, we've added 5 million people to Medi-Cal. We have the largest, we have almost a quarter of the Medicaid population in the United States now in California. We have 12 million covered lives, if you will, in the California Medicaid program known as Medi-Cal. So we by far and away are providing a great influx of health coverage. Yet at the same time, we have these disparities with our chronic disease rates and our trends that are going in an adverse direction. And many of these involve significant disparities for populations of color, where social determinants of health are key. But it's other low-income populations, so we'll hear that. We'll hear about the tribal issue. We'll hear about the Asian population. We'll hear about, rural areas of California as we really dig into some of these issues. Well, Let's Get Healthy California is the overarching plan for our state, health in all policies. So Governor Brown in 2012 had a task force convened which brought together all the constituents and stakeholders on this issue. How can our state move forward with a health plan and make our state the healthiest state in the nation? So by 2022, the goal is for California to be the healthiest state in the nation. The impediment to getting there is that we've got to look at things through the health equity lens. We've got to move the needle on these various indicators, and we have to work collectively. We have to work in tandem with one another, especially where resources are tight. The California Wellness Plan is the operational part of that for the Let's Get Healthy California, which is the state health improvement plan. So every state has its own health improvement plan. Ours is called Let's Get Healthy. The California Wellness Plan brings in lots more stakeholders now. We're getting down to the level of the health plans, Department of Education. Who are all the people who need to be at the table? We're trying to come up with best practice models that will offer these solutions from one community to another community, and where local solutions can inform statewide policy. They can inform the Pacific Business Group on health. They can inform Covered California. They can inform Partnership Health Plan, Kaiser, and others. Kaiser's done some amazing things with blood pressure control, as an example. 90% control of blood pressure. And that's going to make a difference. It's going to make a difference for cardiovascular disease and for stroke in disparate populations and health equity. Here's the National Prevention Strategy. We want healthy and safe community environments. That includes that social determinants of health. It includes the environmental justice perspective as part of our health equity lens. We, of course, want to apply the clinical and community preventive services for diabetes, for cardiovascular disease, for stroke, for arthritis. I don't want to neglect any of my colleagues in the audience who represent the various disease stakeholder groups. Every one of them needs whatever preventive services are available from their healthcare providers, their health plans, their communities. But most of all, we need to empower the people. We need to empower our communities so they can work together on these issues. With that goal, and I always like to say this, elimination of health disparities undergirds our national health objectives. The Healthy People 2020 is our national health plan for improving the health of all Americans. Well, we're trying to do that here in California, so our goal is to eliminate health disparities. That's the social equity lens we want. Last one. Santa Clara County has a robust SNAP education project that helps move the needle for children and adolescents on fitness and nutrition. Water stations, the Community Chronic Care and SNAP Ed program within Santa Clara County. Imperial County was one of those counties that lit up on the slide about asthma. Guess what? Particulates in the air. Things are not good with the air quality in the extreme southeastern portion of the state. But they have a robust partnership led by a gentleman named Luis, who is a community organizer, and he has other influences across Central Valley working on children's asthma. These are examples of local communities who work together with state agencies on policy and systems
It is a pleasure to be with you this afternoon and to be in such good company on the panel. So my name is Kate Morley. I'm the Community Wellness Program Manager at CAHPF Indian Health Project in Bishop, California. What I'd like to do this afternoon is to give you all a brief overview of what some of CAHPF's tribal communities look like, to talk a little bit about the framework that we use for approaching social equity in the chronic disease prevention work that we do, and then to talk about a couple of concrete examples of community-centered chronic disease prevention work. So here's a map of our service area. CAHPF works with 9 tribal communities in Inyo and Mono counties in the eastern Sierra. Our communities are small, they're very rural. We serve about 3,000 Native Americans in both counties combined. Our largest tribe has about 2,000 enrolled members, and so that leaves the remaining 1,000 people to be spread out over the remaining 8 tribal communities. There's a really large geographic spread of the area we cover, and so you can see up there, our main clinic is in Bishop. We've got mountain communities like the community of Bridgeport, California. We also work with the Shoshone Nation in Death Valley National Park. And so what this means is that we have these frameworks that influence the community-level strategies that we implement within each tribal nation or tribal community. And so one of the things that we try to make central to all of the work that we do is capacity building work. And so this can include focusing on the process of promoting health and wellness and preventing chronic disease in addition to just the results. This means that we prioritize skill building, we prioritize training, we prioritize training the trainer models. So we like to hold workshops where our community members can come in, can learn skills and information and tactics that they can go spread to their families, their friends, their colleagues, the people they see at school, the people they see at local parks. We think this is a really effective way to spread our influence of chronic disease prevention, and this works pretty well for us. We also like to focus on community-based participatory research. There is not a lot of peer-reviewed literature that focuses on chronic disease prevention in tribal communities. And so quite often when we go to look for references and information and to try to find models or frameworks that people have used in the past, it's not easy to find. And so we hope that by working directly with community members, we are able to build a stronger evidence base, which will help us and will help people who continue to do this work in the future. I also could not give a talk on chronic disease prevention in tribal communities without at least referencing the phrase of historical trauma, which may be a new one for some of you, but in a nutshell, it's the cumulative psychosocial wounding that is passed on at a community level. And a lot of tribal communities, a lot of Native American communities have a real issue with historical trauma. And one of the ways that we have found that is most effective for counteracting this is a focus on community strength, and to not think about some of the cyclic issues like violence, like poverty, like food insecurity that tend to replicate themselves, but instead to try to see, is there something in a community that is helping it be resilient, and to use that as the base for moving forward. And I also want to talk briefly about community partnerships and about, in some of the examples I talk about in a minute, I hope to explain how some of the work that we do is breaking down the barriers that have traditionally been found between tribal communities and non-tribal communities. And one of the ramifications of that is we often find there are parallel organizations working in a very small area. So like I said before, our communities are small, they are isolated. We often have programs that are run either through the state or through the county, and an identical program that is run through a tribe. So they may be 2 miles apart, but they're 2 separate organizations, and they may not be talking. And so one of our goals is to help make sure that the networks are in place, so that if there is a county WIC program or a tribal WIC program, that those 2 programs are communicating. That if you have city councils or county board of supervisors making decisions, that they are collaborating with their colleagues who are sitting on the boards for tribal nations and who are just running kind of in tandem, that these paths are starting to cross and that we are starting to get a better web of connections for people who are doing similar work. In terms of reaching out to non-traditional partners, one of our favorite strategies is trying to think about how we can take a multi-pronged approach to get at some of the work that we want to see completed. We are a health clinic. We have many providers on staff. We have a couple community health workers on staff. We like to think much more broadly when we think about our Toyabe partners. We will go to local schools. We will go to city councils. We will go to Caltrans, because Caltrans is a partner in helping us think about some work we might like to do with safe routes to schools. We will go to environmental organizations, because maybe some of the park work we want to do would actually help with dust mitigation. It's really windy and dry in southern Inyo County. So there's a lot of overlap that, again, we like to try to take advantage of when we think about building a diverse team that can work on issues that will affect our tribal communities and the surrounding communities. I know that Dr. Sheehan referenced health and health policies, and so I don't want to go into that in depth, but encouraging tribes and community organizations to adopt a health and health policies strategy has been one of our tactics as well. So to think about some concrete examples of the work that Toyabe Community Wellness Program has been doing, we are proponents of multi-use paths. So we think that active living is a really good way to prevent many of the chronic diseases that we see take a toll on our communities. Making sure that it is safe for kids to ride a bike a quarter mile from their house to school is a project that we think has a lot of merit in terms of disease prevention. Same thing with like bike share programs. They look very different in our communities than they do in urban areas. But we, for example, have a community center in the town of Big Pine, about 800 residents. They have a dozen bikes that are available for checkout. So people who don't have access to one can just go in, sign their name, check it out, and ride. And we want to make it very easy and accessible for people to take advantage of some of the resources that our work likes to promote. Community parks along the same line. If kids don't have safe places to play, it's really hard to encourage them to get out and be active. And so one of our strategies has been to partner with local tribal councils and the county parks and rec department to make sure that one, there's good infrastructure, but also that there is good advertising today, and that they're doing targeted outreach to some of the communities that may not normally take advantage of some of the services and resources that are available to them, to make sure that everyone has an equal opportunity to use them. In terms of promoting healthy, affordable food access, one of the projects that we're very excited to launch later this year is work promoting farmers markets. And you'll see there on the right, there's a community that we work with, the Big Pine Paiute tribe, has a farmers market on Fridays. It is, as far as we know, really the only tribal farmers market, certainly in our area and possibly in the state. And they do a very good job promoting consumption of healthy, fresh, local fruits and vegetables. And that, again, is one of those very basic tactics that we think will start to move the needle in terms of chronic disease prevention. That sort of work can go hand in hand with healthy food policies, because many of the employers in our area are large employers, and if you can get them to pass a healthy food policy, it will reach a large number of people. It's much more effective than trying to address some of these issues one-on-one. We think it's got a really broad reach, and so that's been a priority for us, as has connecting growers of local food with vendors. So because our communities are so rural, quite often the people who want to purchase it and then sell food are not connected with the people who are actually growing it. It may be, quite literally, 50 or 100 miles. It may be hours. And so it's our hope that as a community wellness program, we can start to bring some of those people together and begin to create those solid networks so that the people who are growing food can get it to someone who wants to sell it, and then it will actually make its way into people's homes for consumption. And the final example that I wanted to touch on is the smoke-free work that we're doing that relates to tribal casinos. And so there are 2 tribal casinos in our area. Both of them allow indoor smoking. And from a social equity lens, the workers there don't have the same access to clean air in the work site that the rest of us take for granted. And so for us, this is a pretty stark example of there are limited economic opportunities in the area. This is a solid job, but there is indoor smoking, and that is a real health hazard. And so it's one of the issues that we think, if we can address, it will have a positive impact. And the final thought that I wanted to leave you with today is the idea that communities that prioritize preventive health and social equity have a positive influence on individual health behavior. And so we really do think that if we engage in this work at a community level, it will have a direct benefit on individual health. Thank you.
Good afternoon. My name is Dr. Tomas Aragon. I'm the health officer of San Francisco, and I also run the public health services. What I'm going to talk about today, the topic is toxic stress, childhood roots of health inequities, trauma-informed approach to chronic disease prevention. I'm going to give you a few key concepts and just go over some examples on how that trauma-informed lens is having an impact on how we approach chronic disease. The most important message that I want to get to you today, the most important message is that the earliest life experiences are built into our brains and our body for the rest of your lives. Okay? When you're exposed to chronic stress or trauma early in your life, both your brain is forever changed and your body is forever changed. And it goes on to affect behavior and also chronic diseases. This is really clear now. It's really important for us to remember. It's very important for us to remember this. And I'll give some examples and I'll give you an approach that we're promoting. I know this slide is hard to see. These are the causes of premature mortality in San Francisco. On the left-hand side are men. On the right-hand side are women. Leading causes of death: ischemic heart disease, HIV, lung cancer, cardiovascular disease, hypertensive disease, drug overdose, etc. One thing is very clear. You see those circles on the right for both of those? For every leading cause of premature death in San Francisco, Black African Americans have a huge disparity. It is huge across every single one of these. If there were no health disparities, we would see all of these lining up on top of each other. I started doing this for San Francisco in the mid-1990s. 20 years later, it has not changed. That means that what we're doing has to change. We have to have a new approach. And I'm going to suggest to you today that one of the lenses of thinking about early life trauma is one of the reasons why this is so hard to impact. And I'll touch upon a couple of those concepts that are going to be really, really important. This slide here, there's a handout in your packet that has this slide. This is the second thing I want you to be familiar with when you leave here today. On the right-hand side, you see that circle. In that circle, basically, you see the life course perspective: preconception, prenatal, early childhood, middle childhood, and adolescence, and adulthood. The things that impact people early in life persist into adulthood. And guess who takes care of the children? It's the adults. Okay? So it's really important. That'll be one of the messages I'll get to the end, is why we have to work both with adults and children, because the adults are the ones who are taking care of the children. So what happens early on in life? So your brain architecture is determined very early, when you're in utero all the way through. The biggest changes happen up until age 5. The second thing is that our plasticity of our brain decreases over time. So these early years are the really critical years. The second point is, I mentioned, our experiences are built into our brains and our body. When you're exposed to trauma, or what the researchers from Harvard are calling toxic stress. When you use toxic, I'm not talking about chemical toxins. It's really sort of the metabolic toxicity that happens to your body when you're chronically exposed to trauma. It affects your memory, your judgment, and your self-regulation. The very things you need to know to learn and to make appropriate judgments. Okay? So it ends up later on leading to behavioral changes and high-risk behavior. The second thing is that it metabolically changes your body so that you see more heart disease, changes in the immune system, and also changes in metabolism, diabetes, etc. Even when you control for behavioral changes, you still see higher occurrence of chronic diseases in people who have had early life trauma. Okay? And actually, the early life trauma it doesn't matter what race you are, it happens to both races. But because of racism, we see a much higher prevalence in Black African Americans. So the second one there says the biology of health. I just explained all that. The foundations are stable, responsive relationships, safe, supportive environments, and appropriate nutrition. That's number 2. Number 3 is the caregiver and the community capacities. And look over there on the left-hand side is policy and program levers and innovation. These are numbered for a reason. 1, 2, 3, 4. Whatever we do, at whatever level, we want to make sure that it's having an impact down at the individual level, at the level of the household, where the caregivers are having impact with young children. Okay? That's why it's numbered 1, 2, 3, 4. Whatever we do, it's got to be impacting. It's got to be impacting the right hand side. The other important point to point out is that these changes are then transmitted intergenerationally. Okay? It gets transmitted from generation to generation because the children become adults. They don't have the capacity, and it ends up affecting the next generation. Now, I'm going to just briefly give you some examples of how the way that we're thinking about it is that. So what do we do? So in San Francisco, we're taking what's called a trauma-informed approach. We're training our staff and our organizations to begin to really understand, you mentioned some of this, the historical, not just the historical trauma, but the life course trauma that a lot of our clients and patients in our communities have, and some of the concrete skills that we need to be able to engage in the community. One difference is that we work on actually the staff recognizing trauma within our own staff. We have a very diverse workforce. Our own staff that work at the health department also experience trauma. A lot of them work in the same communities. So you have to actually make it the training has to be very personal because it affects not just your client, not just your patient, but actually the staff that you work with. So that's why the trauma-informed training is very important. This is an example here in San Francisco where they're using this at our public housing sites. It's called trauma-informed community building. And the idea here in trauma-informed community building, where there's housing development programs and community building, you see that they're surrounded by trauma. So you might take a program that might work really well in Orinda. Orinda is a nice part of the East Bay. People don't know where Orinda is. You might take something that might just work really well in Orinda. It's probably not going to take off in public housing. There's lack of trust and social cohesion, lack of stability, reliability, and consistency, oftentimes inability to envision the future, disempowerment and lack of sense of community ownership, high level of personal needs, and depth and breadth of community needs. So they take a very specific approach to recognize that you have to meet people where they're at and work with them. And then this is the last slide from the trauma-informed community building approach. The idea of fostering resiliency, strengthening social connections, recognizing trauma, and this is on the left-hand side, you see the socio-ecologic model that most people are familiar with. And our argument is that it has to be deep, it has to get down to that middle circle. It's building the foundations and support so that effective delivery programs and services can take hold, and creating the conditions for long-term community and individual change. I'm not personally involved in this project, but if you ever get a chance and you ever want to learn about it, contact them. The way they will have the meeting with you is they will have you participate in their walking group. That's all they'll do. Come to the walking group and they'll walk with you and they'll sort of show you how things are happening. The next thing that this is at a different level. Now I'm moving a little bit closer to the healthcare system. We've got the CDC REACH grant focusing on the lowest income areas of San Francisco, focusing on African Americans and Latinos, and we're focusing on cardiovascular health. And what I want to point out is what we're going to be doing is we're going to be linking our safety net system to what we're calling community prevention resources. Resources in the community that can support the cardiovascular health of our safety net patients. ACA provides a unique opportunity that where the health system and public health and communities all have the common interest of having good community health. The difference is now is that the idea here is to make it work with our system and then to spread it out with the other systems, the other health systems in San Francisco. But we're taking this again with a trauma-informed lens, recognizing that it's not just a matter of giving somebody a prescription for doing exercise, but really figuring out what do we need to do to work to make sure that they participate fully. And then the last one I'm going to mention is we're doing the Black African American Health Initiative. And this launched in April 2014, and we're working really closely with our Black African American staff. And it's been fantastic. We're focusing on 3 areas. The collective impact is focusing on clinical outcomes. I'm not going to mention that. Our African American staff really emphasized to us that we had to work with workforce development. So we're developing workforce development initiatives within the health department, but also pathways for the community to get exposed to civil service jobs. The last one is a really critical part of trauma-informed training, and that is developing culture of humility. So everybody in the health department is getting trained on culture of humility. Okay? So culture of humility is committing to lifelong learning and critical self-reflection, realizing our own power, privilege, and prejudices, readdressing imbalances for respectful partnerships, and then transforming institutions for promoting accountability. That we have to have a culture of humility in order for us to be able to deal with our own staff, our clients, our patients, and the community. Because it's one part of developing a trauma-informed approach. So, it's the last slide. My main message: early events change your brain, your body for the rest of your life. Ends up changing behavior, memory, self-regulation, judgment, as well as physiologically changing so you're at higher risk of developing chronic diseases, even if you don't partake in high-risk behaviors. So what I'm calling down here at the very bottom, the trauma-informed public health approach is to prevent there's 4 P's in public health: prevention, protection, preparedness, and promotion. The first P here is prevent toxic stress if you can. If you can prevent trauma, it's the thing to do. The second thing is protect from toxic stress. Here's the important role of adults. The adults to help protect the youngest in our communities from toxic stress. Prepare by building resiliency skills. This is really, really critical. Developing resiliency skills in adults, because they need these skills so that they can protect the children. The children are going to grow up to become adults. So it's a circle that we need to address if we're going to break that intergenerational transmission. And then the last one is to promote healthy and enrichment opportunities. If you just do number 4, if you just do the last one, we're missing it. I'm suggesting that in a very strategic and conscious and intentional way, we have to address all of them and make sure it gets down to the level of the young children and their caretakers where they're being protected. So that's it, and I'm going to go ahead and turn it over to Sarah Gugel.
Thank you very much. Sarah Gugel with the California CAHPF Health Network, CAHPF. And what I'm going to do in the interest of time is I'm really going to put the exclamation point, I think, on everyone's presentation so far, because a lot of what has been said, I'm going to reiterate this in a little different way. So the first thing I want to note is that we have the data. For the most part, there's a lot of data out there. My colleagues have really talked about the disparities and where they are. So we know that we have the data. So we need to now move from having the data to really informing policy change that's going to get at those health disparities, reducing health disparities. And in policy change, I think we're really looking at bridging the healthcare system with population health and prevention health. So for a long time, we've been operating separately, and I think my colleagues have really showed how we're trying to bring together how we provide health services, but also where people are coming from, and and ensuring that the primary health, or the primary way in which they live, work, play, and are active, that's also promoting health. And I think we need the resources to be able to do it, so as we're looking at it as a state and how we're divvying up the resources, that we really look with a health equity perspective in mind. And that what that health equity perspective means is that you're also looking at the communities and where they're at. So you're bringing in community leaders, you're bringing in the best practices to really inform that. And finally, that we can't do it alone, we have to do it together. And so just as CPEN is a multi-ethnic coalition, our founding ethnic partners came together in order to really bring together and mold a common goal that would promote the health of all communities of color in California. As a state that is now a majority communities of color, that's the perspective that we also need to be looking at. So just as way of background, and that's a little bit of what CPEN does as well, is we have the data. We're trying to promote the collection and analysis of race, ethnicity, language data, and that we use that to then inform our policy approaches. That we're not just looking at the access to healthcare, culturally and linguistically appropriate healthcare, but that we're also looking at the social environments of the determinants of health. And so these are very quick visuals. Where you see the orange is where the majority of communities of color are in California. So again, really spanning from the Sacramento on down to the lower part of the state. And then where you see the orange here is where you have poor health status of communities of color. So just keep your eye on the orange as I click through these slides. This is where there's lower access to parks, but higher concentrations of communities of color. This is where the food environment is less healthy, and there's a higher proportion of communities of color. And this is where the air quality is bad. So you can see there's a trend over and over again with the same communities that are being impacted by these larger social determinants of health. So again, marrying that promotion of public health and population health with where communities are, and ensuring that our policies are really focused on those particular areas is, I think, the main goal that I wanted to talk about today. My colleagues have really provided some great examples, and so instead of going through more statistics, because I actually don't think that I need to do that anymore, is I want to talk about a couple of additional strategies. So in Oakland, for example, this is, again, I think a really beautiful marriage of the sort of population health and health accesses, Asian Health Services. Primarily, they're based in Oakland, Chinatown. And a lot of what they've noticed was that a lot of their seniors who walk to the clinics were coming in with actually...
The California Chronic Care Coalition. I know that some health departments today are taking the approach of whatever it takes. For example, if someone is supposed to a hospital or emergency and they're released and they're homeless, they'll find that maybe they'll get a hotel room until they recover, that kind of thing. So I didn't hear that approach. It was just pretty much, we were talking about healthcare. But what about reaching out to other partners, such as social services and others? I see more of the health and health policies probably. But can you comment on that, of how that would work in California?
So,
I'm going to try. And Jerry, I'm going to use the example of our new director of public health and the sorts of things that she did in Napa County, where you bring the community together. And here's the issue that we face. We may not have all the resources in the local health department, but we know we have a tremendous need. And eventually the community came together in a way that they were able to solve many of the problems. And, I'm going to paraphrase Reed Tuckson, who, I think some of you in the room know. And at one time he said that we have all the resources we need to solve all of our public health problems. We just have to bring them into the house of public health. What do I mean by that? Well, as you saw the distribution map where the disadvantages occur and the economics, the resources exist in our state and in our local communities. We just have to bring people together and convene them. And I think that convening role can be done by CPAN, it can be done by TOYABI, it can be done by the state public health department, it can be done by the local health department, it can be done by community coalitions, the Chronic Care Coalition. So I think all of us can do this, and it's just bringing all the partners into the house and saying, here's the problem. We don't have the answers. We don't have the resources right now, but we know there's a need, and we know something has to be done. And then once in a while, you're going to find a willing person to step up. You know, maybe it was the case of, you know, the wine industry in Napa, which helped in Dr. Smith's case. And eventually they put some money into the pot. Or maybe it was the partnership health plan that came in to meet some of the need. You just never know where some of those solutions will come from.
So bridging public health and clinical care is really one of the goals for the Affordable Care Act. As we look at health reform, we've been given some incentives. There are incentives for the payers, the health insurers, the health plans, even the hospitals, to hold hands with community organizations and public health departments in order to do exactly what you're talking about here. Find ways to what they're calling triple aim. Better care, better health outcomes, lower cost. And especially when payment reform is looking at things like payment for value or paying for results, we have to think more creatively about how to use the healthcare dollars that are coming in at 18% of our gross national product. We're spending far too much money for far little effective care, or far the care that is not as effective as it should be, because it isn't taking into account the community factors that we've been talking about today, the underlying factors that the medical providers can't touch. Physicians in their office can't necessarily change the social circumstances that are creating the diseases that people are coming to them for treatment for. All they're able to do is give a pill in response, or do a surgery, and then send the person right back out into that social circumstance that created the problem in the first place. So if we're really to deal with this, absolutely we need partnerships in the social sphere, in the economic sphere, in the educational sphere. All of these different sectors have to work together to solve those kinds of issues. And so some of the designs that California is very interested in are surfacing in the 1115 waiver process. We're talking about how to submit a waiver for using Medicaid or Medi-Cal money differently here in California, in addition to just treatment, to extend beyond that and use health promoters in the field so that they can help deal with some of these social problems. Through what was called the California State Innovations Model process, we sent in a tremendously written proposal with lots and lots of public input to the federal government, and unfortunately we're not funded in full for it, but we've got some additional planning money that we're working with local communities very interested in having collaboratives between health systems, health care delivery agents, and the community organizations that aim to work together. All they need is that essential resource so that they can actually do what they're planning to do and bring these programs together. One of the other bright spots we're trying to cultivate here at the pipeline of local communities that are looking at what's called accountable care and creating partnerships between community clinics, hospitals, public health departments, community organizations, social service organizations, and become agents of change by creating better ways of taking care not only of the patients that they're seeing, but the neighborhoods and whole communities that they serve. And this is really how we're going to get a lot more value out of the healthcare dollars that are being spent, hopefully, and be able to replow any savings that occurs from preventing diseases in the first place right back into the system so that they can prevent illness at its roots and maybe create even care opportunities for people that aren't currently being served by the system at all because they can't afford it, or they can't get insurance, which are primarily our undocumented residents. departments here. So finding ways for the system to save money itself and then produce more help by becoming much more accessible for a larger population and doing things through a prevention angle.
I'd like to add to that, to complement what's already been shared, is it's not a dearth of the resources. Like, we have far more resources. It's just how decentralized and how siloed those resources are invested into the same communities. So there needs to be more strategic thought through collective impact. And I've heard both of my colleagues share that. And some of the most innovative examples that I'm familiar with across the state, a good example would be a health system, hospital system that has a community benefit program that instead of doing just grants or any proposal that comes in, looking at, okay, how can we take our community benefit dollars and other resources within the organization to invest in stability of social services or resources such as housing. When the reality is you have preventable, expensive emergency room visits for the medically indigent, for instance. Can they understand that one way or the other, we, as taxpayers or these organizations are going to pay? So it's really about what's the return on the investment by investing in a preventive social determinants such as housing to provide stability for people who might be unstable with respect to homelessness and shelter. And there's a significant return on that investment in being able to stabilize whatever their chronic condition might be, physical or mental. And we think about how do we proliferate and scale those innovative practices. And there's a lot for us to learn from a state perspective, and that there are so many different entry points, either at state, local, or even federal level, into each of our homes. And then homes that are less stable, that have maybe a social worker coming, might have a probation officer, might have a public health interest, so many different entry points, and none of those entry points or resources are collaborating in any way, shape, or form. So it's confusing, it's redundant, decentralized, it's siloed, and oftentimes it's inefficient use of resources. So we have to think creatively and identify those innovative practices. How can we scale them? Do business differently by collaborating from a public and private perspective, and housing is just one good example of how we might be able to do that.
Other questions, comments? I warned you that if you don't come up with something, we'll keep talking.
Hi, I'm Health. I was wondering if maybe one of you at the state level could address what the healthcare is doing to lean on the state's partnership with food businesses that choose to pollute our environments with chemicals. And a lot of the orange areas that were shared are in our agricultural areas. California is the breadbasket of the country. In my mind, public health and environmental health are hand in hand, and that people should have the right to live in an environment that is chemical-free. Is anyone leaning on our state government to say, we want to be the model and not have chemicals in our environment?
I'll take a crack at it. Our Health and All Policies team in the Office of Health Equity staffs the Health and All Policies Task Force, reports into the Strategic Growth Council. There are 22 task force members, and a few of the members that Dr. Sharon highlighted earlier include Cal EPA, Food and Ag, Department of Education, and an array of other State Departments, offices, and agencies. So our model has been fairly progressive since we've engaged these critical partners in health, even though they don't provide health care services. And first and foremost, understanding kind of what's the public health and health equity implications of the policies and decisions of these state departments, offices, and agencies, as well as with those entities, either publicly or privately, that are supported in the community, and thinking about what are the climate implications of what food manufacturers and other entities are doing to unfortunately contribute to the climate health challenges that we have. So it's been a progressive model of first getting these entities to understand how is it that they can look through a health equity lens, and that just like the example that it was either Sarah or Katie highlighted around, no, I think it was Sarah, around AB 441, was it? To encourage this lens approach by, if you're going to make transportation-oriented decisions or food manufacturing-oriented decisions, thinking about what are the public health implications up front. And that way, we're proactive versus reactive after people have already been harmed. So our engagement, there are some examples that I can't give specifically right now. We can follow up and I'll make sure I give you my card. But there are highlighted examples that our Health and Health Policies team can give as to what we are doing, the progress we've made by engaging these agencies, departments, or offices that positively affected and changed some of the decisions and policies that have been implemented over the past few years to mitigate the negative climate effects, as well as the food implications on communities across the state.
I'm impressed by the number of local or regional food advocacy organizations and networks that have come up. Sacramento has a tremendous example. San Francisco, another cluster around Stanford University. They're all over the state and moving in the same direction that you're talking about, being much more conscious about growing local and creating zones for healthy agriculture and local products and production, agricultural production that favors the climate, favors sustainability, favors good nutrition. And this is a movement that's growing. It's growing in force, growing in power, growing in numbers. So it's a very positive indication. And there's a lot of interest in that. And as you understand, food is a global issue. So that a lot of the food that we get is grown in other countries without the same environmental kinds of protections that we even have here. So we've got to be cognizant about that. If we drive business away from being local and grown here, produced here in California, then we lose the ability for even that amount of oversight. So the good news is there's lots more getting done this year than last before, and movement by people both inside and outside of government is really taking this on. So it's a good sign, and I think good progress is being made and will continue to be made because it's of great interest to the public. Yes, sir.
Dr. Announcer, Executive Fellow at the Governor's Office of Business and Economic Development. I just had a quick question and kind of a comment as well. I'm wondering how public health, as we move forward, works to capture the efficiency and potential effectiveness of the private sector. I was down in LA last week at a Advisors in Philanthropy Summit, and a lot of people were talking about different strategies to catalyze impact investing. And one particular venture was to take retired buses and staff them with healthy, nutritious foods, and to deliver fruits and vegetables to different low-income neighborhoods, things like that. I'm just wondering how we kind of change the paradigm from grant making at the nonprofit level to investing in businesses in a return-based model where we can really catalyze this innovative thinking to get products and services to these areas that have really been disadvantaged. Thank you.
That's really a great suggestion, and one that's very welcome, I think, to public health folks. And when you get to the local level, you know, all health is local, all politics is local. And when you bring people together, to go back to that earlier examples, these sorts of solutions come about. So retired buses is what you referred to, where you can actually retrofit them and they become food vans, if you will, for fresh produce going into the community. That's a wonderful solution. And once you hear of a model like that, public health can be part of the sharing network that shares it in other parts of the state. So the networks that exist, and we have robust partnerships. You know, Georgia to be an example, I think, of a best practice. And yes, public health definitely welcomes the private-public partnership that you're suggesting.
I'd be remiss too if I didn't acknowledge the California Endowment and Kaiser Permanente, particularly around their support of our health and all policies team through the Public Health Institute. One of the original investors in grant-making entities to advance our work, and specifically around food procurement, to address your original question, but also to come back to Dahir's point. Part of that innovative work that's being invested in is to figure out and to identify how those kind of local economic development opportunities that address a social need, can be far more common. And one way that we've taken, this opportunity into consideration is looking at our food procurement practices from a contracting perspective. The state is a huge purchaser of food in a lot of different ways, whether it's the Department of Corrections and Rehabilitation, or just as a purchaser for everything from, as an example, our vending machines to other resources that we have around food. But there's a common thread that often comes back to empowering communities by engaging, minority-owned businesses, having supplier diversity opportunities that meet the social need, but strengthen these communities economically. Because as well as I know that economically strong communities tend to be the healthier communities. So I just wanted to make sure I applauded the support of the endowment as well as the Kaiser Permanente and the great work that our Health and All Policies Task Force and team is doing to identify those best practices and then leverage our role to try and scale it and integrate it in how we do business differently.
In San Francisco, we have, out of the mayor's office, because it involves several agencies, Healthy Retail SF for San Francisco. And what they do is they work with primarily with mom and pop stores who are selling cigarettes, alcohol, and for food, and a lot of processed food, to transitioning them to sell fresh food. Working with the whole business process, the supply chain, how to present food. It ends up being a tremendous amount of work, and so providing that technical assistance and loaning in some money so that they can do it. It's not enough to say you should be selling more fresh food. You got to have a whole business process worked out, and so they're developing a really good expertise in that. So it's a resource that people want to access.
Just want to give a shout out to San Francisco Federal Reserve Bank. If you're interested in this at all, go to their website and see. They're a national leader in what's called impact investing, leading the field in thinking and doing with regard to talking about how to invest in rehabilitating communities and investing in social returns, both shorter and longer term returns for the social good. So it's really quite a story. We're at the end of our time, and I'm going to wrap it up today with just a couple of words. We've heard that chronic disease is a formidable but largely preventable threat to the physical and economic health of California. And where we're aiming to deal with this isn't just it involving doctors and hospitals and drugs and surgery, and in fact, maybe especially avoiding that because we know we're overspending and underachieving in that arena in terms of creating better health and greater equity. So our solutions really are aimed at upstream factors, the factors that you and I live with every day in our neighborhoods where we live, work, play, go to school. We've heard about opportunities such as the Affordable Care Act's funding, but it's breathing new life in prevention, but at the same time, it's really quite politically fragile. We have to be mindful about defending the funds that we've already gotten to use to prevent chronic disease because they could evaporate in a flash in today's political environment, and so we need to make sure that people know about the great good that's being done by that. So I just want to let you know that tomorrow a new community of practice is arising here in California involving new grantees that were just recently funded by the federal government, $35 million to 28 communities here in California, added to several hundred other community organizations that have been working to prevent chronic disease and do obesity prevention. Health departments, community organizations, the state health department and the like, are coming together under a great partnership that expects to be the spearhead for innovation here in California in years to come, for ways to do prevention through a health equity lens. So it's really quite a coincidence that this collaboration is coming together. With the support of public and private sector decision makers, we're looking forward to the state tipping the scale toward better health and greater equity for all Californians in years to come. And with your partnership and certainly leadership from all of our communities, especially those that are in most need, we think we're looking at a better outcome for chronic disease here in California in years to come. Thank you very much for attending.
Thank you to Dr. Flores and our panelists. Some of you may have noticed that our presentations were a little hard to read, and it's hard to be far away from the screen. All of these presentations will be posted to the California Health Policy Forum website. Thank you for filling this out, and round of applause for our panelists. Thank you.
Thank all of you. Very good. I like the local perspective. It's really nice to have San
I'll be quick. I came back in, my camera was on, and it's the only time I turned off. God damn it, the wet dot made it. Yeah, I mean, I was surprised it did this well, because I thought it was gonna. The thing with these things is that they can't go too long, like an hour and a half plus, because it just, yeah.